10 seconds each case. 2 patients with the same diagnosis. As I'm sure you know, the skeleton is a dynamic structure. It's not just a bag of bones. It's a framework for attachments of ligaments and tendons. It's a major hematopoietic organ, and it's a major reservoir for calcium metabolism. We're going to talk about metabolic bone diseases today. We're going to define those as various systemic conditions, whether they're endocrine, nutritional, biochemical, or genetic, including, for example, osteopetrosis seen here with diffusely dense bones. What shows up on boards? Well, I'm not here to say, but I do know that musculoskeletal radiologists do like certain things. Osteoporosis, rickets and osteomalacia, hyperparathyroidism, and renal osteodystrophy are perennial favorites. There are some less common ones that we're also going to talk about in the next 20 minutes or so. Hypoparathyroidism, thyroid disorders, acromegaly, and even we'll mention scurvy. What's the most common metabolic bone disease? Well, any educated person should know this one. Worldwide, affecting 100 million people, often resulting in fractures, proximal femur in the spine. Of course, it's osteoporosis. May be defined in various ways. One definition is that there's decreased quantity of bone, thin trabeculae shown on the right. It also can be defined quantitatively as decreased bone mineral density, measured as grams of mineral per unit area. Of course, with radiography, 1/3 to 1/2 of the bone must be lost before osteoporosis is detected, and by that time, there may also be fractures. Dual energy X-ray absorptiometry, of course, or DEXA, is considered by many to be the gold standard for the diagnosis of osteoporosis. And routinely, we look at 2 sides, hip and lumbar spine, unless there's, say, orthopedic hardware. And so if one of those 2 sites can't be measured, an alternative site like the forearm is looked at. So you might think that this would be a pretty good case to be looking at. But it turns out that thus far, anyway, there is no DEXA on oral boards. That's the rumor I have heard as a private citizen, anyway. But I think it's a good idea to know how to approach a case like this, our next unknown case. Differential diagnosis of generalized bone demineralization, sometimes referred to as osteopenia, for example, by Dr. Resnick. So it can be caused by osteoporosis, say in a postmenopausal woman. It can be caused by osteomalacia that we'll talk about, hyperparathyroidism that we'll talk about, and of course, potentially a neoplasm like multiple myeloma that we'll talk about. What about this case? Another unknown case that we should be familiar with having a differential diagnosis for, a case in which there is localized osteoporosis. Here the findings are thinning of the cortex. The trabeculae are decreased in number. There's this patchy demineralization. Whenever we see osseous demineralization, we need to look for complications. That's one of our jobs as radiologists, not just in Louisville. Look for insufficiency fractures that may be subtle complications of osteoporosis. Of course, osteoporosis may, in some cases, look rather aggressive and permeative. The differential diagnosis of localized osteoporosis most commonly in actual clinical practice includes disuse, say after casting of a fracture. Reflex sympathetic dystrophy and transient regional osteoporosis are mentioned in the classic differential diagnoses as well. Now, reflex sympathetic dystrophy, now commonly referred to as complex regional pain syndrome, on radiographs can result in osteoporosis that is both profound and periarticular. On the right, you can see that there is this permeative pattern of osteoporosis that developed over a short time frame. With reflex sympathetic dystrophy or complex regional pain syndrome, bone scan will show diffuse periarticular update. Many regard the 3rd phase as the most accurate phase for showing this abnormality. Transient osteoporosis of the hip is sort of an interesting one as well. Thinking about this entity has changed over the years. First with MR, when people saw edema in the bone marrow that went away, just like the osteoporosis, they called it transient bone marrow edema of the hip. So for example, here 3 months later, that bone marrow edema has totally resolved. Now, many experts believe that in fact, it's often not an idiopathic phenomenon, but often secondary to, for example, a subtle stress fracture or other conditions. So really, transient bone marrow edema of the hip is only a diagnosis of exclusion, and with better imaging these days, we're seeing more and more underlying stress fractures, for example. This is a case of rickets. Note the bowing of the long bones. And at the metaphysis and physis, we have widening and fraying. Now, with both rickets and osteomalacia, there's abnormal mineralization. In kids, the target is the growth plate. We call that rickets. Whereas in adults, it's the mature bone that is affected, and we call that osteomalacia. In both cases, it's vitamin D deficiency that is of principal concern, whether or not that's from liver or kidney disease, GI malabsorption, or dietary deficiency of vitamin D as possible causes. Now, both rickets and osteomalacia can result in generalized demineralization of bone and coarse trabeculation, as we see in these two cases. In rickets, it's the weight-bearing long bones that tend to get this characteristic bowing deformity. And again, look at the metaphysis and the physis for widening and fraying, cupping deformity, or slipping, or Salter 1 type 1 fractures may also occur. Where does it occur exactly in the skeleton? Well, rickets tends to occur at sites of rapid growth, so most commonly the knee, as we see here in 2 patients, the wrist, as we see here in 2 patients, and besides the knee and the wrist, the costochondral junction. We should be looking for bulbous enlargement, the so-called rachitic rosary, characteristic of rickets. What about osteomalacia? The buzzword commonly used here is a Looser's zone, formerly referred to commonly as a pseudofracture. This is an area of unmineralized osteoid. We see a linear lucency traversing usually a part of the bone, and this is commonly regarded now as an insufficiency type of stress fracture through weakened bone. These are often subtle findings on a background of demineralized bone. Common sites to look for these, since you do have to look for these subtle findings: proximal femur, concave aspect, lateral aspect of the scapula, Looser's zone. Here, more prominent Looser's zones in another patient. Next unknown, hyperparathyroidism. Note the subperiosteal resorption bilaterally, as well as this focal area of osteolysis from a brown tumor. Now, hyperparathyroidism can be a primary type in which there's autonomous hyperfunction of the parathyroid gland from a parathyroid adenoma, much more commonly than hyperplasia. The most common variety is the secondary form, secondary to some hypocalcemic stimulus like chronic renal failure or GI malabsorption, and least common, the tertiary form, defined as chronic secondary hyperparathyroidism that results in autonomous parathyroid hyperfunction. Although you're not going to be tested on labs or anything like that in Louisville, I think it's helpful to conceptualize what's going on when the parathyroids are cranking out excess PTH, or parathyroid hormone. That PTH acts on the bone, causing bone resorption and demineralization, driving increased calcium in the blood. PTH also acts on kidneys to cause increased calcium resorption to drive increased calcium in the blood. It turns out that PTH also acts to increase vitamin D levels that act on the intestine to increase calcium absorption, driving increased calcium in the blood. So these are the effects of hyperparathyroidism, increased calcium in the blood. It turns out that with bone resorption, there are a number of different patterns. We may have generalized demineralization or osteopenia, as it's sometimes referred to as, in a classic sense, brown tumors, or other particular patterns of bone resorption that we'll talk about. Now, brown tumors, although they're not specific lytic lesions in and of themselves, are able to be suggested as in an unknown case when we see in the same patient a pattern of subperiosteal resorption, classically at the radial aspect of the phalanges. Here's another case. Maybe you don't see anything at first glance, but if you lean forward and look a little more closely, when you don't see anything at first glance, you'll note that there is this subperiosteal resorption indicative of hyperparathyroidism, something worth keeping in mind. It turns out that subperiosteal resorption can also occur at other places, here at the medial aspect of the proximal tibia. Other types of resorption may also occur, trabecular resorption in the skull, resulting in the so-called salt and pepper skull. Bone resorption can also occur beneath ligaments, and this subligamentous resorption is seen as a subtle finding at the undersurface of the clavicle here. Subchondral resorption also may occur here at the distal clavicle in a patient with hyperparathyroidism. Subchondral resorption doesn't just occur at the AC joints, but also may occur at the SI joints. So it's not only sacroiliitis that affects these articulations. In this particular patient, the clue that is very helpful is that there are soft tissue calcifications in the form of nephrolithiasis. These Staghorn calculi are present and may help point us in the right direction. Next unknown case, 2 patients with the same diagnosis. There's your hint. This is renal osteodystrophy, and the finding is that of a rugger jersey spine, those bands of sclerosis along the end plates that are characteristic. Renal osteodystrophy is defined as the bone abnormalities in patients with chronic renal failure due to both secondary hyperparathyroidism and osteomalacia. So we know what we see with hyperparathyroidism, right? We see bone resorption that's subperiosteal. We see bone resorption that is trabecular, the salt and pepper skull. We can also see subligamentous and subchondral resorption. I just mentioned that as a review because it is a good thing to remember. Osteomalacia is an interesting entity. You can see in these 3 cases, the bone density is quite variable, but in all cases of osteomalacia, the trabeculae are coarse and indistinct. Osteomalacia. Now, with renal osteodystrophy, bones are commonly dense. We should be looking for focal areas of osteolysis, brown tumors, which also may occur. Sometimes we'll also see soft tissue calcifications. It turns out that vascular calcifications are actually pretty common, and occasionally there will be rather distinctive periarticular areas of calcification, sometimes referred to as tumoral calcinosis, although the purists would say that this is better described as dystrophic calcification. We won't spend as long on the remaining entities, but I did want to mention hypoparathyroidism and the close relative pseudo and pseudo hypoparathyroidism. With hypoparathyroidism, there's a deficiency in PTH production. Most commonly, it's post-surgical, and it tends to result in hypocalcemia. What do we look for on our imaging exams? Well, osteosclerosis and soft tissue calcifications are the cardinal features. Here on this coned-down lateral radiograph of the skull, we see a dense frontal bone, but also these subcutaneous calcifications. These calcifications may also occur elsewhere, namely the basal ganglia, as in these 2 patients on CT. With pseudo and pseudo hypoparathyroidism, patients typically are obese and of short stature. It turns out that their fingers and metacarpals are also of short stature as well. With pseudo hypoparathyroidism, shown on the left, and pseudo hypoparathyroidism on the right, the findings are quite similar. You can see some soft tissue calcifications and short metacarpals in these examples. I won't bore you with the particular pathophysiology that is the difference in between these 2. Frankly, I think that you can just remember them together because on imaging, they look very much the same. Just remember soft tissue calcifications and short digits, brachydactyly. A few words about thyroid disorders. Hypothyroidism clinically can result in delayed growth. The goal is to pick these patients up before mental retardation occurs, and certainly this occurs in most cases in the developed world these days with screening tests. On radiographs, not only is there delayed skeletal maturation, but on skull radiographs, for example, Wormian bones or intrasutural ossicles may be seen. In long bones, epiphyseal dysgenesis is commonly found. Namely, we look for stippled, coned, or fragmented epiphyses in hypothyroidism. Although slipped capital femoral epiphyses may occur as isolated findings, patients with hypothyroidism are at risk for this condition. How do we diagnose SCFE? Well, we should know that drawing the Klein line along the superior border of the femoral neck this line should normally pass through the lateral margin of the femoral head. But here it does not, either on the AP or on the frog leg view in this patient with slipped capital femoral epiphysis. With hyperthyroidism, in kids, there's accelerated skeletal maturation, and we don't see much other than in this 13-year-old who has a accelerated skeletal maturation, skeletal maturity of an 18-year-old. In adults, there's increased bone turnover and osteoporosis, not very exciting. Although unusual, there is something that bone radiologists like called thyroid acropathy. It's not very common, occurs in only up to 1% of hyperthyroidism patients, and then usually only after they're treated and no longer hyperthyroid. The features of this condition are fluffy periostitis with soft tissue swelling that is considered actually pathognomonic. Here, another example of thyroid acropathy, that stubbly periosteal reaction, particularly involving the proximal phalanx with some soft tissue swelling. What about acromegaly, excess growth hormone produced by the anterior pituitary? Usually that's from a pituitary adenoma, much more commonly than pituitary hyperplasia. Of course, with a macroadenoma, imaging findings can include enlargement of the sella. In kids, we call it gigantism, where we see advanced height and bone age. In adults, we call it acromegaly, with bone and soft tissue overgrowth in acral or distal regions of an extremity. So, for example, with acromegaly, we'll see a thickened heel fat pad, as well as overgrowth of the bone in the form of heel spurs or enthesophytes, characteristic of acromegaly. Overgrowth of distal structures also occurs in the hands, namely the distal phalanx. There's enlargement of the tuft and the base, causing these spade-like tufts in patients with this condition. Of course, enlarged frontal sinus and enlarged silica also are potential findings. Last unknown case, scurvy. Scurvy, or hypovitaminosis C, results in abnormal collagen with decreased bone production and osteoporosis, as well as hemorrhage. Commonly, this hemorrhage is subperiosteal, and in kids who have a loosely attached periosteum, there can be this very dramatic uplifting of the periosteum like we see in these cases. There is relative sclerosis on a background of osteoporosis at the epiphysis. That's called the Wimberger's sign, or ring, as might properly be referred to as. And at the metaphysis, the white line of Frankel. Scurvy can also be associated with metaphyseal corner fractures or spurs, like we see here. There is a differential diagnosis. Most commonly, it's a torch infection like syphilis, although neuroblastoma and medications like methotrexate may also cause similar findings. That's a quick review of a sort of difficult, tough topic. So we're going to enter the lightning round to really spice it up and make it exciting and really hit the highlights. Okay, so I'm going to describe the findings, and I'm going to need your help in achieving the diagnosis. So I'm looking at this case, and I see, it looks like there's some bowing of the long bone. And I'm looking at the metaphysis and the physis. There's widening, and there's some fraying. This is, everyone, rickets. Oh, it should be like a football game, like a cheering section. I want to hear everybody. I'll even hit the button a little early so you can read it and really, okay. So let's see, I'm looking at this case. I see subperiosteal resorption, okay. I see these areas of lucency that are consistent with a brown tumor. This is, everyone, hyperparathyroidism. Awesome. Now, I had a case exactly like this on my boards, so I think it's worth taking a look at. I see that there are these bands of sclerosis, characteristic of a rugger Jersey spine. This is certainly something characteristic for everyone. Renal osteodystrophy. Very good. It sounded a little bit like church, actually. Okay, so what about this one? I see some soft tissue calcification. I see some brachydactyly. Everyone, pseudo-hypoparathyroidism. Very good. Next, what might we have here? Well, let's not forget that Klein line. We draw it along the superior border of the femoral neck. It should intersect the lateral margin of the femoral head. It does not, either on the AP or the frog leg. This patient has, everyone, skiffy. All right. And patients with hypothyroidism are at risk for this condition. Okay, well, take a look at this one. Check it out. Thickened heel fat pad, heel spurs, spade-like tufts. These findings in the acral or distal regions are consistent with everyone? Acromegaly. Very good.